with this great panel about the Compassionate Use Program. We'll be discussing it with an overview, kind of the history of this program that is now 10 years old. If we can believe it, 2015 it was created, and of course we all know there are continued opportunities for improvement. So if we could quiet down just a bit to make sure that everyone can hear the programming, we'd appreciate it. We're going to go ahead and get started. I feel really grateful to be joined by some folks that have very different experiences with the Compassionate Use Program, and different perspectives, of course, help us to have a really great, well-rounded discussion. As I mentioned, the Compassionate Use Program was established in 2015. We've been working to establish and grow medical cannabis program in Texas for quite some time, and we are happy to see it continuing to grow. So I am joined by Shawn Hauser. We've got Dr. McKenzie and Jervonne Singleton joining us today, and I'm going to let each of you go ahead and just introduce yourselves for a moment. Thank you.
Good afternoon. I'm Shawn Hauser. I'm one of the managing partners at Vicente LLP. We're a nationally focused law firm focused exclusively on cannabis law and policy, founded around the legalization of medical cannabis and adult use cannabis in Colorado, and then working to shape cannabis regulatory frameworks that replace prohibition and support patients across the country. And I lead our Texas practice. Very excited to be back in Austin, where I'm from, and also our federal policy work. Hello, can you hear me okay? Nope. Can you hear me now? Yes. All right. Awesome. All right, no problem. So I'm Dr. McKenzie. I'm a board-certified emergency medicine physician. I'm also founder of Flower MD, where I treat patients or basically try to guide them through the Compassionate Use Program. I've been involved with the Texas Compassionate Use Program for 5 years. At the end of next month, so I'm 4 years shy of 5 years. It's been very different than what I imagined that it would be. It's been very, I guess, I've enjoyed it. I've really enjoyed meeting my patients. I've enjoyed talking to them. I've enjoyed just helping them to find a more compatible form of medicine for their daily journey. I don't know how a lot of people do it in the program, but I actually talk to my patients. I get to know them. They get to know me. I talk to them for sometimes 15 minutes, 30 minutes, 2 hours. I know my patients, and I see when they do well. I see what they struggle with, and I enjoy being someone to help them navigate the system. I've been doing it, like I said, for 5 years now, and I hope to continue to do this for the unforeseeable future. Good afternoon, everyone. My name is Jervonne Singletary. I have the pleasure of serving as the VP of Compliance and Government Relations for Parallel, which is the parent company, The Good Blend. We are one of the three current licensees in the state, and so we have about 3 stores and 7 pickup locations throughout Texas. And just looking forward to expanding the program. Really happy to be here today.
So 10 years ago, they established this program only for those with intractable epilepsy, so severe forms of seizure disorders. And it was very, very limited. In 2017 is when the businesses were first licensed after that passed, limited to only 3. The statute said there needed to be a minimum of 3, and DPS, the governor, decided that they would only do 3. And as we know, until recently, it was only those 3 operators. Since then, though, the program was expanded in 2019, thanks to the diligent work of advocates from across the state sharing their personal experiences, medical professionals coming to share their professional experience, helping lawmakers better understand the efficacy of cannabis, that this isn't just something that people use and okay, they feel better. It has physiological effects in the body, a lot of which we're continuing to learn about through the endocannabinoid system. This is something that a lot of Americans don't really understand, and certainly the lawmakers did not understand this. So it took a lot of diligent work to make sure that they understood it enough to feel confident in establishing the program and then continuing to expand it. First expansion in 19, again in 21, and this year, well, this last year, 2025, a really big year. We officially became the 40th medical cannabis state in the U.S., adding to a long list of states that went before us to bring patient safe and legal access. One of the most significant pieces of expansion was the new qualifying condition of chronic pain. We know that patients use opioids as an alternative, and we know that they're dangerous and addictive. And so now patients have access to that. I want to talk a little bit about the qualifying condition. So let's talk a little bit about what qualified before last year and last year's expansion and what was added. Dr. McKenzie.
So what qualified before September the 1st of 2025? There was seizures, epilepsy, a lot of neurological conditions. So Parkinson's disease, MS, ALS, things like autism, cancers. Eventually, 4 years ago, they added all cancers, not just terminal cancers, and they added PTSD 4 years ago, and then also traumatic brain encephalopathy. Starting September the 1st, 2025 is when they added, most notably, chronic pain, inflammatory bowel diseases, not to be confused with irritable bowel disease, but inflammatory like Crohn's disease, ulcerative colitis. They added hospice and palliative care, as well as TBIs, not just traumatic brain encephalopathy, but injury as well. They added, what was the, anything else what that they added? That was TBI, hospice, and palliative care. Yeah, and pain. Three. Yeah, three. And pain being the very important. We've been trying to get pain in there for quite some time. The most important thing, I think, when it comes to pain, is a lot of times, historically, we've treated pain with opioids. One of the problems with opioids is it doesn't correct the pain. It doesn't definitively treat the pain. It masks the pain. And we know now that cannabinoids, your CBD, and different terpenes can actually reduce the inflammation in your body, which can treat the ultimate cause of a lot of the pain. So you're not just getting a masker of pain, you're getting something that actually helps patients to be able to function better. So that's a very important thing. And on the point of pain and opioids, we're seeing now that we can even use cannabinoids as an exit strategy to get patients off of opioids. I don't know how familiar you are with the opioid crisis, but anywhere from 4,500 to 5,000 people's lives are lost every month from opioids. You know how many are lost from cannabinoids? Zero. That's huge. That's huge. We haven't had one single death simply from cannabis. So that's a really important thing and an important point that we need to make, not just for policymakers, but for healthcare providers as well, because we're constantly okay with writing prescriptions for opioids, but when we're asked about cannabinoids, it's like nobody wants to talk about it.
Well, I appreciate you mentioning this being an exit drug. I heard that first from veteran advocates because we were talking a lot about addressing the concern of cannabis being a gateway drug, which of course is a myth that's been perpetuated over and over again. And instead, veterans have been very clear that this helps them exit the cycle of pills and pain, especially from the VA as their experience. That's all they get from them. And they're looking for an alternative. So I appreciate you bringing that up again, because that's definitely the experience from the advocates that I've worked with. And Jervonne, I want to shift to you on products. So we have new product options now. Let's talk about what we had before and what's now available or soon to be available.
Sure. So before the program and its inception was really limited, and I think the legislature intended to create it that way. And we had oils that we were able to put in gummies. We were able to provide tinctures, beverages, and topicals. And so that was really, really good to treat a myriad of conditions that we were able to treat through the program, right? But as we increased the qualifying conditions, things like Crohn's, irritable bowel syndrome, we realized that those formats don't necessarily work. Somebody who has a digestive issue really shouldn't have a gummy, right? Because they can't digest it. It might irritate them. And so it was critical to get rapid onset products into the program. And we were able to get pulmonary inhalation through the legislation, and that was a huge win. So soon we will have vapes in this program, and that is huge for early onset conditions. If you're suffering from PTSD, you don't have 45 minutes to wait. And so inhalation from a vape 2 to 3 minute onset, you are feeling the recovery. If you're having an acute pain issue, you really don't want to wait 45 minutes, right? And so if we can get you that vape and then you can have that edible that gives you that stayed relief, I think that's a better combination for patients. And so we really are, now we're working with dishes on device approval, and then working with DPS, the Department of Public Safety, on product approval. So we're trying to figure out how to get those things together. But I suspect that working with both agencies, they've been phenomenal. I'll just say that we should get something by Q3 of 2025 and get new products down the pipeline. Additionally, we're working on other methods. So suppositories, those are really critical for certain conditions. So we're going to get those out into the market. And we wanted to continue with our topical line. A lot of folks do not want to feel the experience of intoxication. They just want that point of contact relief. And so we have a really great line of topicals. We're going to be expanding that soon. And we're really just looking forward to continuing to serve the Texas population.
Patches would be included as an option.
Yes.
Because absorption is the language that they use.
Yes.
And you mentioned two different agencies. So we all know that the Department of Public Safety regulates the compassionate use program in general. DSHS, the Department of State Health Services, which manages the hemp side of things, but we'll stay focused on TCUP right now. They've been brought in first a few years ago to add to the list of qualifying conditions, those that are categorized as neurodegenerative disorders. That was the first time authority was delegated to DSHS. They did a fantastic job of creating a robust list of qualifying conditions, things like Huntington's disease, Parkinson's, Alzheimer's, all qualify as neurodegenerative disorders. Now they've been brought in again to do the inhalation device approval. And so we commonly think about vape products, which I think is mostly what it'll be. But would things like inhalers and nebulizers be potential products that could be approved?
They could be. They could be. That's not what we're going to start with, just because we want to present people with things that they are more familiar with, and easier ways to kind of transition into the program. But yeah, nebulizers can be something that we can get approved. So what we have to do that process, if you don't mind me going through that a little bit, as the organizations, we have to just submit to DSHS a form with all of the safety data of these devices, right? The ISO standards, manufacturer guarantees of safety to ensure that these devices don't harm patients at the end use. So DSHS is going to review all of that, approve that device for use, and then we'll be able to approve the product to go with the device.
And I appreciate that background. And there was some advocacy that was necessary during the rulemaking process, because the way that they had proposed the rules was where the dispensing organizations would have to submit vape devices for approval and attest to their safety. I think this was touched on during a panel yesterday. And it seems pretty, or it would have been doctors. It would have been doctors approving or submitting for approval, and instead shifting to the companies makes more sense, because y'all are the ones selling it and need to make sure that it's going to be something safe. Of course, you still need to lean on the manufacturer being the ones who are ultimately accountable. But the advocacy worked in that case. I guess that's what the point I'm trying to make is that it was proposed in one way. They got thoughtful feedback from people and they changed the rule. So it's a success story on how people's voices can make a difference during that regulatory process. And we'll see off and on rules be opened up for consideration, usually after the legislative session, but these can open up at other times. So make sure you're paying attention to those opportunities as we can have the opportunity to fine tune these programs. And you know, we're going to get with you to talk about the businesses, but I want to see if you had anything to add about product availability and the new methods of administration that are available.
No, I mean, I think it's a really significant and important expansion for Texas, and really aligns with what's happening federally, with the federal government acknowledging the medical use of cannabis, and you know, hopefully the evolution of Texas letting doctors practice medicine and knowing what product form and what dosage for specific conditions. Like you said, a suppository may be necessary if you have cancer, and that's something a doctor needs to be the decider of, but that should be available and that the business should be educated on. And I think there's some opportunity for Texas to, you know, use lessons learned from other states and the momentum federally to frankly do this better than other states, especially given the medical community. And one thing I'd love to see in Texas, and I know we're going to talk about program expansion, is to really stand up the CRB research program, because there's, you know, so much
research out there, even observational, that can inform what type of products and to help doctors and businesses best support their patients. But there's also so much to be done and just so much knowledge and medical institutions in Texas. And I think there's a lot we could do with that, especially if Schedule 3 is implemented, which I think it likely will be, rescheduling marijuana from Schedule 1 to Schedule 3, where universities will be more likely to engage in research, and hopefully the endocannabinoid system gets taught in medical school, because it's not, right? And that's crazy. It's a primary system in our body. And so doctors are hungry to be educated, and I think that'll inform what the best products are.
And I think it was last session that they added the research element, if I'm remembering correctly. And it hasn't been taken advantage of yet, but it's a great opportunity because you don't need to go through the DEA to get supply. If you work through the IRB and through the process, and maybe you can touch a little bit more on the details of that, you would be working with one of the licensed businesses in Texas. So you'd be using Texas products, and you'd be able to do research on conditions other than just qualifying conditions. If the commissioner of HHS agrees, then you can study new conditions. And of course, that gives us the data to continue expanding the program and to prove up the efficacy of this medicine.
Yeah, absolutely. And one of the important utilities of state programs is giving access to patients to medicine where it's not legal federally, with a lot of vulnerable populations that can't wait, whether it's veterans or cancer patients, or, people with epilepsy having multiple seizures a day. Like, they're not going to wait for FDA approval and what's happening now federally, which is to try and figure out how to change the federal food and drug laws to allow for botanical drug development, because that's not how it's designed. But there are states like Arizona who have really successful, effective programs where they grant money to state operators in coordination with universities to do this research to inform products. And we're doing it in Texas with psychedelics at a level that we're not with cannabis, and we totally can be. But the CRB program was established, never really implemented. I think there's a lot of engagement that needs to happen with dishes and rulemaking to get it stood up. But what better time than now? And I think that will be a really important component of the success of the program, especially if it's driven by the doctors and businesses.
Well, and the quality of cannabis that we'll be able to do the research on. For so long, it was a monopoly with NIDA for Old Miss providing terrible cannabis, quality cannabis. They would grind up all of the plants and ship that out, and that's what you had to test instead of using real world cannabis that people are actually using. And what better than Texas grown for us to do our own research on?
Well, and the drugs that are approved, cannabis drugs that are approved under FDA, are all synthetic drugs with side effects. And I think, if you read the medical evidence, there's a lot about the entourage effect and the natural plant and its natural alkaloids and terpenes. And that's what's available in the compassionate use program. So to be able to have real world outcomes and patient data coming from those programs, especially with the amazing Texas universities and MD Anderson, there's just so much possible. I get excited about that.
So coming back to the changes that were made to the program, the prescription limits, there were some concerns about how is this actually going to play out? Is this okay? Is it too restrictive? There were two changes in the milligram dosing units. It often talks about a milligram cap. It's a cap on the dosing unit, but not the amount that a patient could actually get. And then the supply, the 90-day supply. Used to be there was no cap on the amount of medicine you could go in and purchase, and now there is. I want to talk to the doctor first about the dosing and how that works, and then also from your perspective about 90-day supplies. Is that adequate? So let's talk about the milligram dosing cap at 10 milligrams rather than just the 1% THC. What kind of practical application or concerns, or is it a concern at all?
I think moving it from a percentage weight down to just the milligram weight, from my practice, it didn't make too much of a difference because patients can still get the amount that they need. I think the confusion is we're not really told what, if any, cap there is for the doctors. We don't get any oversight into how to prescribe, what to prescribe. There's no education for the physicians themselves. You have to take it upon yourself as the doctor to learn what you can on your own. I think that's one of the limitations of the program itself. What I find from some patients who come to me that have been to other offices is they were never even told like what to take, how to take it, who to call, like what to do when, what side effects to that they should be looking for. And I think that's one of the policy things that we can probably improve. Like we need to have some sort of education, CME, something for the doctors who are going to be certified to be in the program. You can't just like throw them out there and expect the patient to improve, especially the way they're supposed to. So what I find sometimes is literally they don't even know what to take. So to your point, whether it's a percentage weight or a milligram, or didn't make too much of a difference because ultimately the mantra is to start low and slowly increase. And you want to stop at that therapeutic dose that helps you feel better, but still allows you to be functional. So whether you do it by percentage weight or by milligrams, it didn't matter. You just still want to start low.
And so a doctor is able to prescribe as much as a patient needs. Just the dosing unit is 10 milligrams. You can still get however many milligrams you need in a day, and you can purchase as much as you need in that 90-day supply. So that's the change in the amount you can come and purchase.
And yeah, yes, we can prescribe whatever we feel that the patient needs. But even as a physician, we still have to be able to have conversations with that patient to make sure they're not ordering too much, they're not getting too much, they're not sharing the medicine. We want to make sure that, we're still doing what's in the best interest of the patient. So on the percentage change to the milligrams, while it didn't make a big difference, it did for the industry itself. Across the country, a standard dose is anywhere from 5 to 10 milligrams. And that's what we're allowed to produce in those individual gummies. And so it was really important to kind of standardize what a dose was for Texas. It was really important to move away from that percentage because it wasn't a standard dose. It wasn't the milligrams. It was just the percent of the cannabis by weight. And so what you were able to do if you wanted to produce an exceptionally large dose of like a 50 milligram gummy, you just added a bunch more sugar and a bunch more gelatin, right? And that's not actually a good way to dose medicine. That's not how you would prescribe anything anywhere else. And so going to the standard dose really does amplify the medical necessity of the program and the medical nature. So that's, for us, it was a really, really important thing to move from. And then to the 90-day supply and the 90-day prescription. So doctors are able to write a year-long prescription for medical cannabis. So however many milligrams that they feel are good for that patient, they're able to write that dose. And then the patient is able to come to a dispensary and pick up what 90 days worth would be in any one transaction. And I think that is a pretty, it's pretty standard across. I don't think that's horrible to say you can come back to us 4 times a year if that's how you want to shop, max out what you're allowed to get, and then go about your merry way. And so I think it's a good way to have some controls in a program. We are still talking about intoxicating substance. We don't want to have it just be out in the ether without any controls. And so for us, it was a good thing to have that 90-day supply with the 4 prescriptions per year.
And that's similar to other medications that you get, pharmaceutical medications. And then just to make sure that we're super clear, you only need to go to the doctor once a year to get your prescription. Yeah. It's just the picking up of medicine that you would do every 90 days or sooner. It's just a maximum of 90-day supply in one transaction.
Exactly. Because think about it. How much medicine would you want in your house at any one time, right? This is still a controlled substance. You still don't want your children or pets to have access to it. And so stockpiling a year's worth of medicine is not the safest thing to do.
So shifting gears from the way that it was expanded for patients and the medicine that they have access to and the ways that they can use it, let's talk about the economic expansion here, the businesses that are now going to be licensed. Can you speak to that process, how many we can expect, and what the timeline looks like?
Absolutely. Yeah. I mean, it's really the most significant expansion that's happened in the program, which started in 2015 and has since been limited to 3 licenses with only, until recently, 2 really being operational. The state issued 9 new conditional licenses a couple months ago, and they will issue a total of 15 with another 3 coming in April. And those licenses will be able to operate multiple locations statewide. They're each assigned a primary public health district to operate in, and then they can have satellite locations in other districts, and multiple locations in those districts, as long as they've set up a location in each of the public health districts. So that should expand patient access significantly, which has been a primary obstacle to the program. But it will certainly depend on these new conditional licensees getting up and operating. Right now, they have conditional licenses. They have to stand up their facilities, get inspected to ensure they're compliant, they meet the standards in the program before they get an actual license to operate and be able to serve patients. And, given how much of this expansion is, how big this expansion is from how limited the program is, it's all going to depend on, I think, if the state's engaged right now. They've got a small team at DPS servicing 3 licenses pretty close to Austin. Now they've got the whole state to cover and get inspected and licensed. And, there's a lot of investment and time that's got to go into setting up these satellite locations. I agree with you. The CME education to me is a critical component of the success of the program and getting doctors engaged and enrolled and equipped to prescribe these new product types, equipped to prescribe cannabis. Patient and doctor participation has been a challenge in this program because of the way it's been designed. So I'm hopeful that, the new just volume of licensees, with a combination of Texas folks, of those who are coming from other states, that we can really empower and fund and activate doctors and patients to educate folks in the program. And then, maybe the elephant in the room is, how is this going to intersect with the hemp market? Texas is unique in that its medical program is expanding into a robust hemp market where there's a lot of access to all types of product forms, without these types of geographical or operational restrictions. And, what's going to happen with the hemp program is going to be under consideration with the agencies federally and at the state level, throughout the year. So, if the responsible folks in hemp and the responsible folks in marijuana can work together to look at how we're going to, regulate cannabis responsibly for Texans and educate everyone from consumers to doctors and patients, I think the expansion can be very successful. But it's going to require a lot of work by everybody. But 15 licenses with multiple locations is significant, and coupled with the conditions, adding chronic pain is generally the key to expanding the doctor and patient population in many states. And there's just so many folks that suffer from that as a result of so many conditions.
And one thing you mentioned is satellite locations. And I want to talk about the significance of that. Not a business, not just having to have one location doing the delivery, and making the kind of makeshift drop-off situations. Jervonne, would you talk to us a little bit about that, the challenges you were facing and why this change matters?
Yeah, satellite locations and overnight storage is going to be huge for the program. Before we're housed in Austin, so that's where our borough is. We would have to, at first thing in the morning, load up all of our pre-orders. So patients would have to go maybe sometimes a week before and say, hey, I want these 7 products. Okay, this is the delivery schedule for this week, because now we've collected enough orders to get out to, say, Nacogdoches. So we've collected 7 orders. It took us a week to do that. So the patient had to wait a week. We're going to drive to Nacogdoches. Maybe we're going to stop by your house on the way there. We'll give you a 10-minute window. Hey, meet us outside, get your product, and then we're going to keep on driving to Nacogdoches. If you miss that 10-minute window, we're going to keep it in the van and bring it all the way back to Austin at the end of the night. And that was our delivery model. It was highly inefficient. It took a really, really long time. And that's really what made the program not successful. There's no reason a patient should not be able to say, I want this product, and go into a store same day within the same hour and get that product and bring it on home. And so with a lot of advocacy, we were able to get overnight storage into the program, which means that we can store products in our dispensaries now overnight for as long as we need to. Patients can come in day of, get an order, leave. They can do a pre-reservation. We can operate like an actual brick and mortar store now. And that will, right, as the program expands, as the new licensees come on, reduce some of those delivery costs and burden to the patients. And that those reductions in costs are definitely going to be passed on to the patients. So we're really excited about the reduced costs that come about as overnight storage, and just the broader access that we're able to get to the state.
There was one provision in HB 46, which is the expansion bill from last year, that I'm not real clear on exactly how much good it does. It sounds good. It's patient privacy. It means that the patient's information in the Compassionate Use Registry of Texas, which they call CURT, is private. Only law enforcement has access, doctors, and the dispensing organizations. But I kind of thought that was already the case. Do you have any insight into what this new privacy provision adds to privacy provisions?
What I think it adds, right? And I'm not the attorney here, so I will definitely let Shawn opine on that one. But it adds another layer
So
of
many people into it.
feeling protected patient, right? We always want to ensure, especially when you're writing legislation, that everything is written down in that bill. You never want people to assume the intent behind the legislation or assume how far the bill goes. And so codifying that really does go far to say these are the only 3 people that have access to this information. And it gives the patient a sense of just calmness about their information being out there. We are still talking about a federally illegal product until we get to Schedule 3, right? Or still talking about it's still, right? And so there are so many things that come along with that tack on impacts to that. And so if we can codify, these are the only agencies that have this information and they're using this information for this exact purpose, it really does limit the way other people can think that they have access to that information.
Yeah, and I would just add that it's a really important piece, obviously, patient privacy, and the program does classify patient information as confidential, meaning it's not subject to an open records request or released, other than as necessary to a doctor or law enforcement personnel during enforcement. But I don't think it goes far enough. And if you look at patient protections and cannabis programs across the country, Americans for Safe Access actually ranks them in their strength, and that's both the protection and the punitive measure for violations of privacy. And there's a number of states, I think Maryland is one, and there are some southern states like Alabama who have both the protection and some, I think, very good teeth on the punitive pieces. So that may be something to look at. But I think the change does have some good, strong protections for patients in line with HIPAA.
I would like to add something on protections that probably goes a little bit further than just privacy. I think with patients, they don't want to just know that their information is private. They also want to know that they're protected in using the medication that's helping them to feel better. And that we lack those laws that actually protect the patients in accessing the medicine, in using the medicines, in the workforce, whether they're in a CPS case, whether they're on a probation or parole. We lack those protections for the patients. And we've seen it done in other states. It's not like we can't do it. We have Missouri who has a constitutional protections that literally says if you're part of the medical cannabis program, you cannot be violated on your probation, on your paroles. We have statutory guidance for that. There's no reason why we should have a medical program that doesn't protect the patients and allow them to have access. Like, how can you have medical access, but you don't really have protections for that access?
Yeah, I think it's a great point. And it's patients and doctors too. And other states do a much better job, and they're not always the California's, Colorado's. It's like Alabama, Louisiana. So there's some clear civil practices, and the CPS issue is very real among others, and gun rights. Like, there's all sorts of reasons a patient would think twice about signing up for the program. Sure, they shouldn't need to.
Yeah, that's right.
Doctors too.
Yeah, and this was a really clear transition into opportunities for improvement. This program is not ideal. There still is room for improvement that we hope to happen sooner than later. Legislative session starts soon. So getting into, let's continue the conversation on patient protections. We had a whole session yesterday dedicated to this, and anybody missed that, we'll have the videos available. They dove into these issues very deeply. Dr. Rice-McKenzie has a personal experience with one of her patients going through an issue. Are we going to share that story with us?
I could share it. He's okay with me sharing it. He said that I can share it. So last summer,
I received a phone call from one of my patients who was letting me know that he was going to have a parole violation, which would mean that he might end up back in jail for 7 years just for being in the program. He applied for the program in December 2024. His reason why he was on probation was a DWI. But he was on probation. He did everything right in terms of his probation. He finished his inpatient rehab. He was 3 weeks away from finishing his outpatient rehab. And the only thing that really helped him to stay sober from alcohol was medical cannabis. He did not test positive at all for alcohol while he was on medical cannabis. When he brought it up to his probation officer, she told him, no, absolutely not. You're not going to be allowed to use medical cannabis. So he did what she asked him to do. He stopped using his medical cannabis. And unfortunately, he backslid because that was the thing that kept him from using alcohol. There's research that shows that using medical cannabis decreases the urge for alcohol. It decreases the consumption of alcohol. We have something that helps patients and people in the way that we're asking them to be helped, but we're not allowing them to do it. That wasn't, to me, it didn't protect him. I didn't protect him. The state didn't protect him. He has a program, but he can't use it. So now he's in a jail cell for a 7-year violation, all because he was using a medicine that helped him feel better. But the kicker in all of it is the probation officer and the judge, they're okay if he used opioids. They're okay if he's used benzos. We know that those have a worse safety profile than medical cannabis. The research has shown that there's no reason why he should be in trouble for using something that helps him to be the person they actually wanted him to be. That's just not, we should be able to do better. We have a huge policy gap here. No, absolutely. And that is so tragic. And it really highlights the disconnect between federal law, state law, and then how it's interpreted by everyday bureaucrats who really have untold power on people's lives like this. That parole officer could have acknowledged that this is a legal program in the state. All they had to do was do a little bit of research, and it didn't have to happen that way, right? And so what we're dealing with are a lot of antiquated attitudes that go down into these organizations, into your line employees, and it really is going to take a concerted effort. And it's unfortunate that cannabis has such bad PR, right? And that opioids have better PR. I'm not trying to trivialize it, but honestly saying that we've taken this plant-based medicine and demonized it in ways that the real demon, opioids and fentanyl, don't have to deal with. And so how do we change those attitudes and heart and minds are really going to be what drives the program successfully nationally and into the future.
Such a great point. And, kind of comes down to a lot of the work that we've been doing is trying to help people better understand cannabis, breaking down that stigma, putting our best foot forward with professionalism. And it's still as important today as it's ever been as we continue to help cannabis go mainstream, which is another session happening right now upstairs. There was another thing when we had our conversation earlier to help protect patients, and all of that kind of leads to that point of ID cards. Texas is one of the few where we don't have a med card, a cannabis card. We just have an entry in a registry. Will you talk a little bit about your idea of why we think we should have that?
Sure. I love medical cards. I think just having that actual ID gives you a lot of protection against normal everyday law enforcement interactions. If you are pulled over by police and you have your cannabis on your person, even if you picked it up from the dispensary, they may say you should not have drugs in the car, because that's how that law enforcement officer wants to interpret the law, right? And interpretation is so critical in this point. And so if you have this ID, it takes away the need for interpretation. You're a medical patient. You're protected under the program. There's no more reason to interact and inquire about the cannabis on your person. And I just think it would go a long way, one, to help individuals feel safer, right? So I think people are really hesitant to get into this program because of some of the law enforcement implications. And then it would help clarify what's legal and what's not for law enforcement. There still are way too many drugs in our community. And so how do we suss out what is supposed to be there and what's not? And I think just having ID would go a long way of just clarifying some of that confusion.
May I?
Yes, please.
Yeah, I agree. Having some form of medical cannabis identification card, or at the very least, some type of standardized form that every physician, every clinic in the program will use. Right now, I have my form. The next clinic has their form. The next clinic has their form. Nothing is the same. And so when companies like ask their employees, well, do you have proof that you're in the program? And you give them my card or my form, and they're like, well, this doesn't look like Dr. XYZ's form. How do we know you're in the program? There has to be something standardized. And I know like there's always like the fear that, well, it can be copied, it can be forgerized. I mean, so can driver's license, but we still have them. We should still have some way to prove that the patient is in fact in the program. And you can always add a QR reader that links back to the registry, that has an initial on it, that has an expiration date, something to help continue to protect that patient. And again, just not only the patient, but the confidence in the community to know that the program really exists, because a lot of people don't know that it exists. Even my doctor, when I told my doctor 2 years ago, it was the first time I met her for one of my physicals, and she asked me, what do I do? I told her what I did. Oh, you're not going to go to jail for that. There's still a lot of stigma, a lot of myths out there for the program. We need to do better. If we're going to have the program, do it 100%. Let's do it. Make it safe.
And so shifting into some of the challenges working with regulators, operating freely and as freely as you can in such a highly regulated space. Let's talk about some of the challenges of working with the DPS. Obviously, law enforcement regulating a medical program is less than ideal. Certainly wouldn't have been our choice. I think that there were some reasons behind that. They manage prescriptions for other drugs like prescription pads. So that must be a really great way to do it. Obviously, there's a cultural shift happening in the country, in Texas, and even in DPS, in helping them to recognize this is actual medicine, not criminals. And that shift in their minds is something that now we're 10 years later and there still is so much tight control. So I want to open it up. I know that both of you have worked with DPS. Obviously, you're in the registry, but working with DPS, what are some of the challenges and how can we work with them better to improve the way that companies can operate?
Yeah, no, I would say, and having worked in a lot of states with agencies, it's been a challenge. I mean, I think they always haven't been supported by leadership and implementing and being stewards of the program, but also, like you said, being a law enforcement agency. But unlike other states, just to get some basic answers to questions for whether it's licensees or potential new entrants in the market, like sometimes you have to hire a lawyer and a lobbyist to get an answer to a question, which is ridiculous. And it may be that they don't know the answer. A lot of the rules in Texas are sort of an unwritten playbook. But it's also, they haven't been educated and equipped to implement a medical program for the size of Texas that we need. So I think that's hopefully something that will change with the expansion. But I don't think, like in other states, there's been the level of stakeholder engagement. There's been the level of improving the rules. We've had many years where there's been rulemaking processes and just non-controversial issues like product storage that all the licensees need to function basically and get medicine to patients, but they never changed. But ultimately, I think a lot of that comes from the top too. So it's kind of a PR campaign and getting leadership to see the cannabis as a medical issue, which now the president does. He was very clear in his press conference and the executive order that he understands the medical utility of cannabinoids, and that is what he's going to do federally. So I'm hopeful that that's something the Texas leadership can see, because I think they will drive what DPS does ultimately.
Yeah, I echo those. I mean, DPS is a small but mighty team, right? There are about 4 people on that team managing the entire program for the entire state of Texas. So I'm going to give them just a little bit of leeway there, a little bit of grace there. But as more interest comes into the program, they're going to be resource constraints. And so I really do hope that the agency staffs up a little bit so that they can get out to the more remote parts of the state. Rulemaking is going to be critical, right? A lot of what we have been able to work with the DPS in the way has been more handshake agreements. And as we get the program more professionalized, we're going to have to get those rules on paper. And so I look forward to working with the agency, helping them in ways that we can, right? We are the subject matter experts. And I appreciate that the agency looks to us for guidance as they're devising their rules and as they're devising the regulations, because they realize that they don't know it all. And so unlike a lot of other states where we work and people feel that they are the experts and they are the ones in the room, it's more of a collaborative nature with DPS. Slow, I will admit, but collaborative. And that I really appreciate.
Well, I know they had a working group that they put together, and I'm not sure how much opportunity there was for that working group to have an influence. So I was disappointed to see that. I mean, you talked about that limited team, but the licensing fees are outrageous. $500,000 almost for first 2 years, and then $315,000 after that. So it's not a matter of lack of resources. So I hope it's an initiative now that this is expanding. We're in a new era, offering grace where we can, but also pressure, because this is a matter of government accountability. This is making sure that the program is working for those who it's intended to work for. So we will continue doing that work. I would be happy to open up for questions. We've got another 10 minutes with this session. And so we've got a microphone there. And if we can just keep them quick, because we've only got 10 minutes and I want to hit as many questions as we can.
Oh, yes. I have the question for the Dr. McKenzie. Are you listed on the CURT with the DPS?
Yes, I am listed on the CURT. I always have been listed on the CURT.
Okay. My reason why I asked is I found a doctor in my town that's listed, and he's a neurologist, but he says he's been on there about a couple of years, but he hasn't been go ahead to start, giving help to patients. So my question to you is, what type of hurdles and red tape did you have to go through to start helping patients, and how long once you got on the CURT, how long after that did it take you to start being able to help patients?
Those are great questions, and I feel bad that he didn't get as much information as he needed to on the program. I was fortunate when I got into the program. I actually worked under a different physician. I worked under another physician, so I had a lot of information in terms of how to navigate the program. So I didn't have those hurdles. I will say, when it came to being in the program and actually being able to deliver the care that one needs to as a physician, that was left on me. There is no education out there for the state of Texas for medical cannabis education. You have to do that on your own. So what I ended up doing, because I did my residency in New York City, so by the time I did the CURT registry, I knew that New York had a program. So I used all of their medical education and then medical education from other states as well. But I wouldn't imagine that most people would do that. But I was also fortunate, like I said, that the doctor that I worked under, she had a lot of protocols. She had taken the time to write down every single product that every single dispensary sold. And she cared about patients. She cared about patient safety. If you're doing it on your own, it would be difficult. Not impossible, but you would have to just be self-motivated to do it.
Okay. Well, I'll take the opportunity mentioning CME that our friends with Credo Science, Dr. Ethan Russo, they have an outstanding curriculum, all CME accredited, available on demand. And in your program, in one of the ads, there's a QR code. So if you're interested in CME credit, you can check that out and learn from the best. Dr. Ethan Russo. Yes, sir.
Hi, everyone. My name is Kwaku. I work for Dutchie, which is a point-of-sale technology that operates in 7,000 dispensaries, more on the license side. My question's for Jervonne. Obviously, there's some expansion in the program now. We're moving towards pulmonary products and inhalables, I suppose. I think the future that we would love to see is getting to a point where we could have farmers market style cannabis. But in lieu of that, what's next on your wish list as we look towards 2027, 28, and continue to expand the TCUP program?
Sure. Well, that's a really, really good question. Hi, Dutchie. Really appreciate all the help you give us in other states. So as we get into 2027 and as we approach the next legislative session, chief on my list of things that I want to advocate for is the introduction of flower into the program. Flower really is most patients' first access point to cannabis. It provides, I don't want to say the most benefits, but it really does provide the whole flower benefit, entourage effect, terpenes, and everything else. And I think it's what's missing in this program. Now, I will be the first to say I'm not going to advocate for a combustible flower. I don't think the state's ready for that yet, but there is an opportunity to talk about vaporizable flower in this program. So that's going to be the first thing that I advocate for. Additionally, I want to expand the conditions list. I think that physicians know best what their patients need. And so we should really be opening that and saying, hey, if you and your doctor think that cannabis can serve you, we're going to let you do that under a doctor's care. And so giving more responsibility and onus back to individuals for their care decisions. I won't go on to the rest of the list, but those are the two things that from my advocacy standpoint, I'm going to be petitioning the legislature for in 27.
No, I would second that. A lot of states have a condition that's a condition your medical professional thinks the medical benefits outweigh the negative. And that's the practice of medicine. So letting doctors practice medicine, which seems also right for a state like Texas.
Crazy idea. I mean,
Yeah, I have a question for the good plan. We know, the DPS released a license, okay, and you can manufacture your product, and also you need a test, right? Okay, so for the testing, do you run a testing in-house in the same facility with the manufacturer? Okay, and those testing team is run by a independent, like the chemist, analytical chemist, or is it's kind of like your own everything. Everyone is your own employee.
So everyone is our own employee. The person who does our analytic testing on our team is employed by Goodwin, but they are a chemist and they have their own ethos and operations, right? And as a company, we don't want to ever hurt our patient. That's not what we're here to do. So we are double, triple checking our COAs. We are double, triple checking all of those test results to ensure that what we say is in that product is in that product. That is our reputation on the line. But that is a very unique situation, right? Most states would not allow the manufacturer to test the product. You would want a third party to do that. And let me be the first to say, I'm not opposed to that. So if that's something that the legislature wants to do, because I trust the products that I produce, I have no problem with a third party coming in to test our products.
Yeah, actually, Texas is I guess, is the only state in the nation they allowed producer to testing a product report. Okay, so do you have any accreditation, like ISO 17025 or something like that? Do you have that in the house? Like,
yeah, we do.
Okay. And also my another question, do you think this TCUP for your business is kind of like the good profit source?
Well, there are about 139,000 patients in the Texas program, and we have a state of about 30 million. So we have not reached the potential that I think the program should reach. So I'm not going to say profitable or not. I'm just going to say that the program has not reached the patient threshold that it needs to be a sustainable program. And that's where all of you folks in the room are really going to come in and into play, right? The only way we're going to make this program work is if we get more patients in the program.
And also, the Texas right now still has kind of like the gap or loophole. The gap means like the TCUP and Delta 9 is separate. It's not clear, but it's kind of like separate, because other states they try to convert the TCUP by 0.877, right, to the class Delta 9 together, total Delta 9 TCUP. Okay, so in that case, because Texas also has a consumable hemp program that's under the HHI, like a human public service. Sorry, the health service. Okay, do you feel like there is a competition for the sales, because you sell your product, but the hemp producer, they can also sell their product once they say, hey, my TCUP may be high, but my Delta 9 lower is low. They can sell their gummies. You sell your gummies. Do you feel competition?
I mean, the hemp industry is going to exist in some form or fashion, so I'm not going to call it competition. We all sell the same plant, essentially, right? And so we can all get in the same sandbox and find some regulations and work to create an industry that works for everyone. The people who come to Good Blends have very specific reasons for coming to Good Blend. The folks that want to utilize the hemp-derived market have their own specific reasons. I'm not going to demonize either one. And I think we, like I said, we can all exist in the same sandbox.
What a fantastic note to end this conversation on. Yes. So thank you, ladies, for being here. You know, the Compassionate Use program is going to continue to evolve with work from advocates. It's growing now with new businesses coming in. It's such an exciting time for cannabis, including the growth of the Compassionate Use program. So help me thank our panel.